Good afternoon. Can you hear me? Yes. So good afternoon, everybody. I'm here. I'm thrilled with some good friends, Dr. Chiastra, Dr. Bourantas, and my co-chair, Dr. Foin, Nicolas. Let's get started. I think it's an interesting session. We're going to talk about simulations, bench computational simulations, and how this can help us advance our knowledge and understanding in bifurcations. I think it has been an essential and integral part of the program. Dr. Borzota, right? We have this every year here, and I think the knowledge we learned out of this has been phenomenal. So let's start with, also in the panel, I don't know how many of those are here. We have, or we're supposed to have Susan, Bayer, Francois, Derimay, of course, Christos is here, Paul Iazo, I hope he's around, and Dr. Desai. Let's start with, please come, join us, of course. India is key in the whole operation. So let's start with Dr. Maaroufi. Thank you, sir. Please take the podium. Stenting technique for a left main trifurcation in a bifurcation conference, bench testing. We look forward. Yeah.
Hello, everyone. It's a great pleasure for me to be with you today in order to present our work entitled In-Bench Assessment of BCI Techniques for the Treatment of Complex Left Main Trifurcation, which is a collaboration work between Gemelli University Hospital and our center heads Centrum of Graz and Turuma. So, as we may know, left main trifurcation represents 10 to 15% of left main disease. And actually, it goes without saying that it's a complex lesion. Why? Obviously, because it includes 4 angles. There is quite a big discrepancy between sizes of the left main and the side branches. And also, there is different involvement of the ostia of the side branches. So, and also, there is scarce data about the optimal stenting technique in this context. So for that, we performed an in-bench testing that was used 3D printed silicon bench models with distal reference of 3.5, 3.0, 3.0 mimicking LAD, intermediates and circ, and the left main here was 5.0. And each stenting techniques, actually, we try to adapt bifurcation stenting technique to the trifurcation configuration. And each stenting technique was performed by 3 different groups of experienced operator. And all the procedures were OCT guided and analyzed by micro-CT. Unfortunately, the results of the OCT analysis are not done yet, so I cannot share that with you today. However, we can show the micro-CT analysis, and we can, all of us, reflect on the stent deformation in these cases. So starting with provisional. So as we may know, the provisional starts with LAD towards left main stenting. Then we perform a POT. Then here we have 2 configurations. The first configuration is to rewire through 2 different cells, neighboring cells, as distal as possible. And the other configuration would be to try to rewire through the same cell. And then there is 2 scenarios. One of them would perform a tracing, and the second one would perform sequential kissing. So let's go to see how it looks like in terms of this scenario, which is rewiring through 2 different cells. So this is the theoretical sketch about how it should look like. And this is the micro-CT when we performed a tracing, and how it looks like after we perform sequential kissing. So I think we can all appreciate there is more stent deformation when we perform sequential kissing compared to the tracing. Now we go to rewiring through the same cell. And here we can see that when we perform the tracing, there is less scaffolding of the carina between the intermediates and the circ, and the sequential kissing performed more stent deformation. Now let's move to two stents techniques when the intermediates should have been stented. So here we go on with the steps of the provisional, starting with the stenting from the LAD towards the left main, performing a part, rewiring and tracing, and then we put a stent into intermediates. We perform another part, rewire, and then another tracing. And here's how it looks like in these configurations. Actually, there is quite a good amount of stent deformation in that sense. And in terms of culotte, which is deca culotte adaptation, when the circ should be stented, here we start with the steps of the provisional, and then we put a stent towards the circ, perform a part, rewire, and perform a tracing. And here how it looks like, and actually from the micro CT we can say that there's less stent deformation than the previous one. Now we move towards the crash, and here we start with the circ stenting first. We perform our crash, tracing after rewiring, then put a stent towards the LAD and then a pot, rewiring again, and then a final tracing. In here, how it looks like in terms of circ stenting with the crush technique. And then we go with the intermediate stenting, put in the stent first, crush it, rewire and tracing, put a stent in the LAD and pot, rewire again, and a tracing. And this is our final results with more scaffold deformation in the proximal part, but the carina between the LAD and the intermediates seems quite acceptable. So, take-home messages. Provisional offers simplicity, as a better scaffolding and less deformation in case of rewiring using different cells, followed by tracing, but may not be suitable to all complex cases. Culotte provides coverage and good size side branch access, less stent deformation in the case of LAD and circ stenting, which is a wide angulation, and crash is effective in certain scenarios, especially when the intermediate is severely diseased, but can lead to high risk of compromise of the circ. And thank you.
That was very interesting. So, what is your final recommendation when you have a trifurcation?
Still, we cannot conclude any recommendation from that. Still, I mean,
your experience, in vitro experience.
I have to agree that, personally speaking, I don't have much experience in terms of trifurcation treatment, but from experienced operators, we should try or aim for one stent as much as possible. That would be the aim, but not all anatomies would be suitable for that. So whenever we can end up with one stent, that would be the first strategy. So we go with the provisional.
And if we cannot end up with one stent, then we go for 2 or 3 stents?
2 stents.
2 stents. So it seems that, Francesco, the concept, you've done lots of work on trifurcations in the visual heart lab, visual heart lab in Minneapolis. So is it correct to claim that when you have a trifurcation, try to pick up the 2 worst vessels and fix those and avoid the 3rd stent?
So if we see the appearance of we see the appearance of stents implanted in the perfect control you may have in a room where there is no beating heart, like in the bench test he reported, you clearly understand that to change the tubular stents and adapt them to trifurcation is very difficult, and the interaction between the metal at the end makes very unpredictable the final results with fancy images at the end. So to me, the number of stents you implant in the trifurcation increases just something that we know is unpredictable. So I feel that the recommendation for left main treatment and our team central role should take in care the fact that trifurcation makes PCI much cumbersome, and we have actually no final solution for them. So if there is extensive disease in all the branches, we know that PCI will be imperfect, and 3 implants or 3 stents will increase the chance of having funny solutions at the end.
And one question, in your bench study, so you kind of optimize always the way you recross through the stent, right? You checked where you were recrossing.
Yeah, exactly. I mean, all the steps were guided by OCT, so we checked about our rewiring, where our wire is using OCT.
Because that's an important point. If you don't check, I mean, if you don't know where you recross, the more recrossing, the more chance of getting a mess. So in the bench, it looks good, but in reality, there was another point. The bench model that you have is rigid, right? The walls.
Somehow rigid, yeah.
Somehow, because you don't see then the effect of 3 overlapping balloons, which, if it would not be rigid, would deform the proximal part as well. You see what I mean? If it's constrained.
Yeah, because I mean, we could not like exceed the size of the model itself, while the vessel itself could, like, we could overstretch it, which could lead to more deformation.
Anyway, in this bench test, we applied the POT. We applied the POT, and we know that there is, the potential to let the stent become a little bit more round shape with the addition of it. And this is silicone, for sure. I mean, in the humans, there is the possibility that the eccentricity in the expansion is related with the plaque presence. So it is, you are true.
Correct. So let's, quick question, quick answer.
My question is very, very different in the sense that left main bifurcation or trifurcation is totally a different disease with calcification and things. Here you have 3 rigid tubes. So how do you translate these tests onto real world scenario where there may be a lesion in the side branches also, whether they would remain the same where there is calcification also, where you are not able to get good expansion of the distal left main? Would these results be reflecting in the true world scenarios as far as the lesions are concerned?
I think, like, in terms of lesion preparation, they should go through what we already know, like, in order that if we need debulking devices, then we need to perform debulking devices before going on with the stenting technique. So debulking the calcium is like a step before going with the stenting. So the stenting should be only like the last step after good lesion preparation, I would assume.
Okay, let's thank again the speaker.
Thank you so much.
We can now introduce the next speaker, who is Dr. Takayuki Okamura. Okay, he is online.
Yes,
and
thank you for
okay, please start.
It's my great honor to meet this meeting. The title of my presentation is Optimization of DK culotte stenting in a novel left main bifurcation bench model.
We don't see the slides.
Yeah, it's my COS, right? Dear Chairman, thank you for inviting me to present at the EBC 2024 meeting. The title of my presentation is Optimization of DK culotte stenting in a novel left main bifurcation bench model. Yeah, it's my COS, right? The culotte technique is considered more physiologic than other two-stent techniques due to several structural advantages, such as full coverage of bifurcation segment, minimal or absent neocarina, no triple layer, and preservation of the stent tubular architecture. However, these structural advantages can be achieved only in case of perfect performance, which might often be limited by certain technical restraints. In the culotte stenting, limitations in the angiographic field of view increase the risk of improper rewiring. Vessel foreshortening, overlapping projections, and cardiac motion may hinder accurate guide wire manipulation. Additionally, selecting an appropriate stent design and size may be crucial. we developed a novel beating left main system that simulates left main motion using systolic and diastolic morphological data from 210 patients who underwent coronary CT angiography. Using this model, we conducted 3 bench tests. In study 1, we investigated the influence of left main motion on distal rewiring. In the static model, distal rewiring was successful in 100% of cases. But in the motion model, the success rate dropped to 60%, which was similar to previous clinical study. Study 2 examined whether 3D OFDI guidance improves the optimization of DK culotte stenting. Stenting was performed under fluoroscopy according to previous consensus documents. In this study, synergy 3.5 mm and 4.0 mm stents were implanted in the left main LCX and left main LAD respectively. OFDI images were obtained after rewiring and the final procedure. In the angio guidance group, the OFDI images were blinded to the operators. In the OFDI guidance group, rewiring was adjusted based on 3D OFDI findings. After the first stent implantation, the success rate of distal rewiring on the first attempt was 60% in both groups. However, in the OFDI group, successful distal rewiring was achieved 100% of the time at the kissing balloon inflation. Following the second stent implantation, neocalina was observed in 40% of cases in the angio group, but only 10% in the OFDI group. The success rate of distal rewiring was 50% in angio group and 40% in OFDI group. Ultimately, the OFDI group achieved a 100% success rate. In summary, successful distal rewiring both after the first and second stent implantation occurred 30% in the angio group and 100% in the OFDI group. The classification of optimal rewiring positions after the second stent implantation is illustrated in this figure. ESA at the bifurcation was analyzed in the final OFDI pullbacks. ESA at the side branch ostium was significantly smaller in the OFDI guidance group compared to the angio group. However, ESA at the opposite side branch slightly increased in the OFDI group. The same bench test was performed using the 3.5 mm Megatron stent, which has a larger expansion capacity. Secure distal rewiring with OFDI guidance reduced ESA at the side branch ostium, regardless stent size and design. While ESA at the opposite side branch increased with the synergy stent, this was not observed with the Megatron stent. Overall, ESA in the bifurcation segment was significantly reduced in the OFDI guidance group with Megatron stent. Micro-CT analysis revealed a significant reduction in the ESA volume in the OFDI guidance group compared to the angio group, particularly at the LCX ostium and carina. Additionally, the minimal stent area at the LCX ostium was larger in the OFDI group than in the angio guidance group. I'd like to conclude my presentation. To optimize culotte to stent technique for left main bifurcation, even with the DK approach, side branch rewiring under 3D OFDI guidance is recommended. The classification of optimal rewiring point, including neocalina after second stent implantation, has been defined. Distal rewiring with OFDI guidance consistently reduced ESA at the side branch ostium, regardless of the stent design and size. ESA at the opposite side branch tended to increase after KBI, potentially due to the maximum expansion capacity of the stent. Therefore, stent with sufficient expansion capacity for left main bifurcation should be used. The potential for DK culotte stenting under OFDA guidance to improve clinical outcomes in left main bifurcation must be validated in future clinical trials. Thank you very much for kind attention.
Okay, thank you, Dr. Okamura. Can you hear us?
Thank you very much.
Yes. Can you hear us? Yes.
Yes.
Okay, great. So, very interesting talk, very interesting experimental setup, which include the motion of the heart and the impact of the motion on the coronary bifurcation. So, my first question as an engineer is, could you comment more on this setup, on the importance of including the motion inside a bench test?
Yes, thank you very much. I think the cardiac motion under fluoroscopy, cardiac motion, we can see the left main bifurcation. So under fluoroscopy, so it's very bizarre or bizarre. So we cannot manipulate the guide wire accurately. So I think the bench test, including the cardiac motion, is very important, I think.
Dr. Okamura, very interesting presentation. I'm Dr. Bourantas from UK. With regards to the motion, I have seen that the entire coronary tree is moving, but I have not seen a separate motion of the circumflex and the LAD. And this is critically important when we try to assess PCI results, because there's also prognostic benefit. The change in the angle during the cardiac cycle is associated with, provides prognostic implications and has been associated with stent failure. Is that possible to optimize that and include also the motion of the coronary arteries, taking account CT angiography data?
No. In this test, we analyzed only the motion of the left main and totally, not individual vessels. So we cannot assess the impact of the each motion so on the remote prognosis. So only the we can assess only the acute phase.
Yeah, obviously.
Only the procedure.
Yeah, so Dr. Okamura, our job here is to keep pushing. This is a very first attempt of adding motion into a bench model, which is, you have to be commended for this. But definitely now, next year, in the upcoming, with the upcoming efforts, you should refine it better so that you include more comprehensive, more patient-specific motion in your modeling. But this is a very great first attempt and very helpful to get more insight. Let's, in the interest of time, let's move to the next speaker.
Okay, so I'm going to introduce Pawel Gasior. I think he's not here, so he's doing the talk online. And it's provisional stenting in LM bifurcation setting, CFD, OCT, pilot study in human. Can we have him online?
Dear Chairman, thank you very much for inviting me. I am very honored to be able to present the results of the study provisional stenting technique in the left main bifurcation setting, computational fluid dynamics and optical coherence tomography pilot study in humans at this year Eurobifurcation Club meeting in Frankfurt. My name is Pawel Gasior and I'm speaking on behalf of all of the authors of the manuscript published in the Polish Heart Journal. First of all, I would like to say a few words of how we came up with the in vivo human study. So first, we conducted an ex vivo benchtop study in which we compared the latest generation drug-eluting stent, in this case Science Sierra, and we implanted it in the bifurcation model. The silicon model, the sizes were 3.5 millimeters in diameter of the main branch and 5.5 millimeters in the left main. And we implanted this stents using the keep it open technique versus kissing balloon inflation technique. And as a comparator, we use bifurcation dedicated stent. In this case, it was a BIOS stent from the Bolton company. And in this study, we evaluated OCT analysis of thrombus formation at 60 minutes following stent implantation. And first of all, we found out that the percentage of floating strat was statistically higher in the keep it open group when compared to kissing balloon inflation group, which was of course expected. However, we did not found any differences in terms of thrombus area between kissing balloon inflation and keep it open group. Furthermore, we conducted CFD analysis based on the OCT images, and we found out that the high shear rate area was statistically higher in the keep it open group when compared to the kissing balloon inflation group. Also, maximal shear rate was higher in the keep it open group when compared to the kissing balloon inflation group. Also, we conducted the analysis of drug coating damage under the SEM, and we found out that the drug coating integrity was significantly more impaired when kissing balloon inflation technique was adopted when compared to the keep it open strategy. And previous meta-analysis of randomized trial demonstrated similar clinical outcomes regardless of side branch optimization with the kissing balloon inflation technique. However, up to date, there are no large randomized trial focusing on the impact of final pot after kissing balloon inflation. Therefore, we decided to move forward, and we designed pilot study in humans in which we aimed to evaluate the impact of kissing balloon inflation followed by final pot in the left main intervention based on OCT images and computational fluid dynamic reconstructions. All interventions were performed using Science Sierra stent from the Abbott company, and we included in this pilot study 3 patients. So first, we of course did coronary angiography and the baseline OCT, and after selecting appropriate sizes for the balloons for the preparation and stent sizes, we implanted the stent. We of course prepared the lesion, implanted the stents, and then performed first pot, after which we performed OCT, in which we evaluated how everything turned out, and we also confirmed if we were if we crossed after rewiring, if we crossed the distal cell of the strat. Then we performed kissing balloon inflation, after which we again did OCT evaluation, and then we did a routine final pot, after which we performed final OCT evaluation. And here I would like to present the representative results, representative images from our patients. So the mean left main MLA before PCI was 5.28 square millimeters, and the maximal shear rate was 483. And then after peridiolytation, implantation of the stent, and first pot, the left main MLA, of course, increased up to median of 8.34 square millimeter. We found only 3 malappositions in the left main, and we found 44 floating strats at the ostium of the side branch. The median maximal shear rate increased to 1066, so over 2-fold from the baseline. Then we performed the rewiring, we did kissing balloon inflation, and we performed another OCT imaging, in which we found that the MSA at the left main stayed basically on the same level, slightly increased. There was no difference in the terms of malapposition because they were really low after the first pot. However, we found a 25% decrease in the number of floating strats, And we found further increase of median maximal shear rate up to 1,779. So over threefold increase from the baseline. And then we did final pot, after which we again evaluated the OCT images. We found that the LM MSA significantly increased up to 11 square millimeters. There was no change in malapposition or floating strat. However, what is interesting, the median maximal shear rate dropped from over 1700 to only 487, which was most likely associated with correcting the elliptical shape of the left main after a kissing balloon inflation and restoring circular shape after final pot. So in summary, based on these preliminary results, we demonstrated that performing kissing balloon inflation without following stent optimization may disrupt stent geometry unless it's followed by final pot, which is associated with numerical improvements of OCT morphometric parameters, as well as reduction of floating strat at side branch ostia, and the area of high shear rate in the CFD analysis. This shows the potential of kissing balloon inflation followed by final pot in further reduction of the number of adverse events in patients with distal left main stenosis. Nevertheless, larger studies evaluating the impact of side branch optimization are crucial to further explore these preliminary findings. Thank you very much again, and if you have any questions, I am open for discussion. Thank you.
Thank you. Do we have Pawel online? Not sure.
Yes, I'm here.
Okay. Any question for Pawel?
I have a comment, and I'm sure that you will comment on this, Nicola, because you've done lots of studies and published actually great papers in the field. So great job here. The point is that there's a big debate to kiss or not to kiss routinely. Hemodynamically is way better when you kiss versus no kissing. We restore better hemodynamics. The question is, what's the biological response? Because you end up injuring a vessel, a side branch, without covering this. And the data, at the end of the day, the clinical data don't support the routine kissing. So there's no clinical data, no clinical trials saying that kissing is better than non-kissing. So even though hemodynamically is better, maybe there's some other factors which make it look probably not beneficial. So how do you comment on this?
So thank you very much for the question. So in our practice, we do not perform kissing balloon inflation routinely. It depends how a vessel looks after the implantation of the stent using provisional stenting technique. Also, as I demonstrated with the first ex vivo bench test study, we see way more bigger drug coating damages using kissing balloon inflation versus not performing it. So this might be another point why not to do kissing balloon inflation routinely. However, in our practice, generally, if we don't see any side branch compromise following the pot, we do not plan to perform revascularization in the distal part of the side branch in the future, we don't do routinely kissing balloon inflation.
I have a comment. Fantastic work. We learn a lot from this kind of analysis, and it's coming from a group that's very active in the field. I've seen the change in the CR rate. It's really impressive. This is the average CR rate, however, if I'm correct. Have you looked at it's not the average value that matters, though. Mainly is the peaks that you have, which is the cause of thrombosis, and the lows as well, CR rate values, that plays an important role. We don't need neither very high or neither very low CR rate because there is a risk of thrombosis. Did you look at the distribution? Was it much better, the distribution after pot? Or there was still areas with very low CR rate? For example, in the crash strats.
Actually, the only two parameters that we looked during this analysis was the area of maximal shear rate, which basically was highest after kissing balloon inflation, but it was very slight numerical increase, and the other parameter was the median maximal shear rate. So we did not evaluate the parameters you were talking about, but that's a good point, and we will definitely look at it in the future. But I will have to discuss it with our friends in Singapore who performed this analysis, and we have to see if this is doable using the 2D models reconstructions using the OCT imaging.
Yeah. One more question from my side. Did you analyze the data on the basis of the type of balloons which you have used, whether it's semi-compliant, compliant, and the size of the balloon? Does it make any difference as far as the final analysis is concerned?
So during this study, we for the kissing balloon inflation, we used semi-compliant balloons. For the predilation and the proximal optimization technique, we use NC balloons. However, we did not perform any analysis if the kissing balloon and optimization using semi-compliant or non-compliant balloons alters the results. But this is a very good comment, and I think this might be a subject for another study, and maybe we will investigate it in the future. Thank you.
Okay, I think we're done. Thank you, Pawel. Thank you very much.
Thank you so much for the invitation.
So a very quick comment by Rajiv. Yes.
For proximal optimization, we should also think of using semi-compliant balloons, because often, for example, a left main is not uniformly sized. So a semi-compliant balloon in a left main possibly makes more sense.
Point taken. Point taken. Let's don't start a new kind of like a session here for this. Maybe a topic for next year. We move to. Okay, Francesco, you promised 10 seconds.
I promise 10
10.
seconds.
I start counting.
Congratulations, because this is very important studies. The methodology is new, and the results clearly document one thing, that all the literature we know about kissing cannot be applied to pot, kiss, pot. That is indeed what you documented. So to me, the historical data regarding kissing cannot be translated to the practice of decision doing or not kissing, because you documented that applying a RPOT, we increase the result and we change the flow at the end.
Okay, all right, clear. So again, thank you so much. A big applause here, please. And we move forward with Daniel Taylor, systematic review and meta-analysis on the Marius law in the coronary arterial circulation.
Hello, good afternoon, everybody. My name's Daniel Taylor. I'm a clinical research fellow at the University of Sheffield, and today I'm going to be talking to you about how big should bifurcations really be. I'm presenting a systematic review and meta-analysis of Murray's law in coronary arterial bifurcations. You're probably all familiar with Murray's law. It's a fundamental principle of bifurcation physiology, first described almost 100 years ago, and it relates diameter and flow in all branching trees, including the coronaries. I'm not going to go into too much detail about the physics underlying Murray's law, but there's two key equations that are important for what I'm talking about today. The first one relates the diameter of parent and daughter vessels around a bifurcation, and the second describes flow splitting between the branches. And it's important that these are all related via a cubed exponent, so a power term of 3. And why do we care about Murray's law for interventional cardiology? Well, there's a number of reasons. Principally, it's used in bifurcation PCI, and it's used to derive minimum lumen area targets. And Murray's law-derived lumen area targets were validated prospectively in the landmark LITRO study. And Murray's law is also used for computational models of coronary physiology, tools such as FFRCT, which you may use in your practice. However, despite having stood for almost 100 years, recently Murray's law has been challenged, particularly that cubed exponent of 3. Murray's original law considered only a bifurcation in isolation, but newer theoretical work by Huo and Kassab, which considered the distal resistance of the entire coronary tree, suggested that that cubed exponent should actually be reduced to 2.33. And observational data quantifying Murray's exponent is somewhat equivocal. There's a large range of numbers ranging from about 1 to over 3.0. And while the difference between 2.33 and 3 may seem small numerically, it can have significant implications for artery sizing in bifurcation intervention. so what we did was we conducted the first systematic review and meta-analysis of Murray's law in coronary bifurcations. The aim of this was to quantify a pooled or optimum flow diameter exponent in all articles quantifying it in Murray's, quantifying an exponent in epicardial and transmural bifurcations. We included articles, or we screened articles, over 4,500 of them, and 27 articles quantified Murray's exponent, and 18 were suitable for meta-analysis. These 18 articles included data spanning over 60 years. First one was published in 1963. And they included data from over 1,000 unique coronary trees, and the majority of these were human. And our main headline result was we quantified an optimal exponent of 2.39. So this showed excellent agreement with the Hughes-Kassab law with an exponent of 2.33. And our confidence intervals were fairly tight on this, 2.24 to 2.54, which effectively excluded Murray's original exponent of 3.0. And some key secondary findings that we had: there was no difference in exponent value between diseased and healthy bifurcations, no difference between epicardial and transmural arteries or humans and animals. And so one more time, just to hammer home the result, an optimum exponent of 2.39 for coronary bifurcations showed excellent agreement with the theoretically derived value of 2.33 by Hughes and Kassab. And this has implications for the diagnosis and treatment of coronary bifurcation disease. It's a bit of a good news story for PCI. It implies that for our parent vessel, we should be going for larger MLA targets, so more PCI. And the equations that I showed you on the first slide, I've got them rewritten there with the meta-analysis result of 2.39. But some of you out here may be thinking, but there's another law that I use to size coronary bifurcations. What about Finay's law? Well, Finay's law is an observational law derived from IVUS examination of 173 healthy bifurcations. And it's much simpler than Murray's and Hughes-Kassab laws, which are power relationships. Finay's law is a fractal law. And it says that the diameter of a parent vessel should be approximately equal to 2/3 the sum of the two daughters. And this simplicity has made it popular in bifurcation intervention. You can see at the bottom of the screen, I've got a screenshot of the EBC home website. And on there, the Matterhorn is literally pointing you towards the EBC diameter calculator, which uses Finay's law to tell you how big the parent and daughter vessels should be in a bifurcation. One important technical detail to note about Finay's law and how it differs from Murray's and Hughes-Kassab is Finay's law implies that the power law exponent can vary over the coronary tree, and that variance occurs with vessel symmetry. So for symmetrical vessels, Finay's law would imply an exponent of 2.3, and this exponent would increase with vessel asymmetry. And so what are the implications of all this? We did the first comprehensive systematic review and meta-analysis of Murray's law, which included data from over 1,000 unique coronary trees. We derived an optimal exponent of 2.39, and the confidence intervals on that excluded Murray's original exponent of 3.0. These results showed excellent agreement with Hughes-Kassab and also Finay's law, but on the condition that a bifurcation is relatively symmetrical. As bifurcations become increasingly symmetrical, our meta-analysis results conflict with what Finay's tells us. And what does this mean for bifurcation PCI practice? Well, at the bottom here, I've got a screenshot from the EBC most recent consensus statement. And one of the big targets is to respect the original bifurcation anatomy and physiology and try to faithfully reconstruct this when doing bifurcation PCI. And the EBC currently recommends that we use laws of Finay, Murray, and Hughes-Kassab in doing this. But I would suggest that maybe the results of this meta-analysis say that Hughes-Kassab is probably the optimal law that we should be using. Finay's law is appropriate under conditions of a bifurcation that's relatively symmetrical. And the meta-analysis results suggest that maybe we should be moving away from Murray's law. Thank you very much. I do have a tool that I can use to show you the difference live of what these different laws and exponents mean for bifurcations, particularly parent vessel diameters. I'd be happy to take any questions.
Okay, thank you very much for the presentation. I can start with one question. So maybe I didn't catch at the beginning, but did you include in all the bifurcations only humans or also animal data?
We included humans and animals. Humans was our primary outcome, and I've got plots further on in my slides if we want to see. There was no difference between humans and animals, and about 2/3 or 3/4 of the bifurcations we included were from humans.
Okay, so this means that if you repeat the analysis, removing the animal data, you obtain a very close number, 2.3.
Yeah, I've got the slides. I mean, the slides are finished now, but I do have the forest plots. There is no significant difference between them. The confidence intervals overlap.
And for the general cardiologists, interventionalists who, already Finney's law, most of them maybe don't know about it. So what is the shortcut that you can give them as a recommendation in terms of sizing the proximal? Is Finney acceptable or not?
Well, the results of this meta-analysis suggest that Finney's is acceptable if you've got a symmetrical bifurcation, and most epicardial bifurcations, particularly left mains, are generally symmetrical. But what do you mean by symmetrical? So say in a left main bifurcation, you had an LAD and a left circuit that were above 4 millimeters in diameter, that would be perfect symmetry. So it's the ratio between the two daughter branches. So something like an LAD into D1 bifurcation is typically more asymmetrical.
Please.
Sorry, I have a question. Thank you very much for your presentation. Great work. And what about the physiological assessment, angio-based? I mean, you have suggested that the angio-based physiology assessment could be impaired from this Murray law, and the most recent tools that we are going to use in the next year are based on the Murray law. So do you think we should wait for using that, or do you think they are underestimated, they are overestimated?
So I think it probably depends on the tool you're using. If you're talking about virtual FFR rather than absolute physiology, so milliliters per minute, for virtual FFR, the difference in exponent can change your 95% confidence intervals by about 0.1, kind of the upper threshold, plus or minus. It is very case-specific, though. It depends on how much taper you have in that case, where the stenosis is located. So it's difficult to give a concrete answer for VFFR.
Thank you. So maybe one day we will have the Taylor's law?
Maybe. I'll be very pleased. And Morris, who's my supervisor, who's sat over there.
I think maybe you should come up with some.
Please use the microphone, please.
Perhaps if you came up with a size matrix, it would be easier. You have the data. You just need to make the matrix so you can read it off a chart.
I have prepared an Excel spreadsheet. If I don't have anything to type with, but I could show you in real time what difference it makes.
Is it possible to put the slides again? We have 1 minute left.
Is there a factor you recommend? For example, you have 0.678 for Finney's law, for Hoek-Asad law. What factor do you, for quick analysis in the cath lab when you're stenting, what factor do you recommend for Hoek-Asad law?
So I'm not an interventional trainee, so it's difficult for me to give an answer in the context of what it's like in the cath lab. But given that the current state of bifurcation PCI strives to restore as faithfully as possible the anatomy, I would say the results of this meta-analysis suggest UO-CASAB is the most accurate theoretical law. From our work, 2.39 would be the best one. I know it's difficult to do kind of not even cubed or square roots of 2.33 in your head. But maybe with developing practice, we had tools that could quickly calculate them for us, and that would be possible in the cath lab.
So practically, when we see this judging of the sizing on the basis of the Murray's or the Finney's or CASAB law, but when we do actually the procedure, we have been guided by the imaging. So does it make any difference as far as the law is concerned, an analysis which you can state that this is going to be the law for determining the sizing of the vessels?
So if I understand your question correctly, if you use Murray's law, then that would underestimate the MLA for a parent vessel So if you've missed some disease that's still there on angiography, you wouldn't see that. Does that answer your question?
Is there a correlation with imaging and the loss? That's what.
So is there any correlation you have done with the imaging and the law or interpretation of the various
laws? You will
laws?
see that tomorrow afternoon. So you have a complete session tomorrow at 6 p.m. So my word for Dr. Taylor is that your last sentence is respect the anatomy or restore the anatomy. So I think this is, we are writing our slides since maybe 10 years or 15 years. Thank you very much for promoting this.
Thank you very much.
Thank you. Okay, so I can introduce now the next speaker, Dr. Gianluca Rigatelli. And the title of his presentation is Resident Time in Complex Left Main Bifurcation Disease After Stenting.
Thank you so much for the kind invitation. Can I have my slide, please? All right, thank you. Okay. We know that computation fluid dynamics may help to understand and preview the rheolytic effect of the stenting techniques in different anatomical situations. Blow stasis concurs in the development of intrastent stenosis and the development of coronary artery disease after the coronary stenting. Third, residence time has recently emerged as a novel computation fluid dynamic derived model of blow stasis. We try to evaluate differences in wall shear stress and residence time after complex left main bifurcation stenting. So there are a number of parameters on computation fluid dynamics that you can compute. We have to focus to the relative residence time, and is the inverse of the time average wall shear stress forces vector magnitude, and it represents a measure of solute residence time in proximity to endothelium. It means that how much time the blood stays there in a segment of the vessel after you put a stent, right? We know for other previous study we done in the last 10 years that different double stenting technique have different computational flow dynamic results and profiles. Usually the techniques that have less metal and at the carina site are more respectful of the anatomy and of the rheology of the vessel. On the contrary, techniques that have much more metal at the carina, like decay crush, culotte stenting, TAP also, may have less beneficial profile and less respectful profile in respect of rheolysis of the vessel and the physiology. So residence time is just a matter of flow, fraction, times, and it means really how much the flow and the blow flow stay still after we put a stent. The tasks involved in performing a computer fluid dynamic simulation are more or less three: image acquisition and segmentation to reconstruct a 3D patient-specific coronary model, computational fluid dynamic pre-processing to discretize the domain with meshes and define the boundary conditions, and solving the fluid governing equation using the fluid solver and post-processing to visualize the flow field. That are from a review by Professor Kasab and first name Liang Dong on frontier physiology, and it reassumes what is the process of segmented imaging, have the computational flow dynamic, have the virtual version on, and to develop a computational flow dynamic study. So we retrospectively review our local OCT scans database between the last 4 or 5 years, and searching for unprotected complex left main, treated either with single or dual stenting strategy. The inclusion criteria were cases having an unprotected left main coronary disease, 111 medina, and complex as per definition trial criteria, treated with PCI stenting using single or double stenting technique, and to have a complete run on both LAD and CX before and after the procedure run of OCT. These are also the exclusion criteria, but I don't want to bore you about. We assess three techniques: provisional stenting, decay crash, and non-inverted T-stenting, which were performed as recommended by current EBC consensus. So at the end of the day, were 27 patients, 10 patients received crossover, 17 were treated using 7 patient decay crash, 10 patient NIT technique. This is the measurement on OCT, just to give you an idea of the diameter, pre-stent, post-stent of a left main, and proximal LAD, LCX in provisional decay crash and NIT patient. There are not too much huge differences. Just to remember the nano-inverted technique, in the past was called, we call it nano crash, and then we changed the name just to be more consistent. Very briefly, the only things that differentiate this from another double stenting technique is that the side branch is covered as a mixed coverage, in part from one small shoulder of the first crown of the side branch stent, and the other by the strut protruding from the main stent into the side branch. So it means that you have not to be so much precise in putting the side branch stenting before, because really it doesn't matter how much you cover the ostium, because the complete coverage is given by the, in part by the left main stent. Just the difference with the other technique, the nano-inverted T has got double part. So patient-specific geometry has been reconstructed using the ANSYS and the modeling toolkit from Bergamo. For each reconstructed 3D coronary model, the fluid domain was discretized using the ISM-CFD. And at the end, we have some evaluation of the work shear stress forces. And you see that non-inverted T has the higher average work shear stress force at the carena, at the side branch, and the main branch compared to the Cape Crash and Provisional. That's again is the average work stress value. This is, I pick up just a patient among the 27. Just it is in the middle. It's not the worst. It's not the best. It's just in the middle. And you see here in red the work shear stress forces as low, and in blue are high. So low may be worse, red may be worse, and blue may be better. So you see here the incomplex bifurcation provisional has got some very low work shear stress forces average compared to the K crash and NIT. And looking to the focus of the study, this is the average resident time after left main stenting using the provisional decay crash and NIT. And usually, intriguingly, the provisional approach in complex bifurcation has got the worst result in resident time. The best result in resident time is a non-inverted T, followed by decay crash. And surprisingly, provisional has not got the better result, the best result. There are provisional stenting generate a higher resident time value is located to the lateral walls of bifurcation opposite to the carina. In comparison, decay crash has a higher RIT at the carina in the proximal side branch, and non-inverted T show lower RIT values in the entire bifurcation segment. This is the mean resident time changes in the entire line left main bifurcation using the tree technique, and you see again the Provisional has got not the best result in complex bifurcation. It's something that surprised me, because when we consider the study, we want to check if Provisional has got the best profile also in complex, not only in simple bifurcation. So at the end of the day, I concluded my study here. First, evaluation of resident time by computational flow dynamics offer new insight and understanding the impact of complex stenting techniques in complex clinical scenarios. The study suggests that in complex left main bifurcation disease, double stenting technique will have a better impact on long-term clinical follow-up, and this is also shown by the clinical data, actually. In provisional stenting, the site with higher RIT values located at the lateral walls of bifurcation opposite to the carina, and may explain, at least in part, the higher rate of restenosis in the main branch, which have been estimated by previous analysis in complex bifurcation, ranging between 5 and 14%. So, in complex left main bifurcation disease, 90 appears to have a more favorable CFD profile with lower RIT and higher Gaussian stress forces, but it is only in complex bifurcation. Thank you.
Very much. So we have space just for a very quick questions, two couple of questions.
Thanks for the very nice talk and presentation. So a question for you and Claudio, if he has been involved. So I don't understand the mechanism of action. Like, where does it come from? The fact that provisional may have a higher residence time. So one idea, is it related to the changing the angles with two-stent technique that kind of straighten a little bit more the bifurcation, or what is your hypothesis?
I think that one of the explanations is yours one. I mean, maybe the two-stent configuration helps to keep the bifurcation angle of the carina a little bit more, anatomical respectful than the single stent in complex. Complex means that the bifurcation is disease also and the side branch in the left circle, and for a certain length and with a certain calcification. So we are not talking about a silicon model or a simple bifurcation, left main, distal left main crossover, and it is. It's a complex bifurcation, so maybe that putting two stents help to enhance, incrementing the flow velocity in the vessel, and so in maintaining high the Gaussian stress and low the resistance time.
Very interesting work. Very interesting work indeed, and we're learning a lot from this kind of analysis. Just a quick question. If I understand well, you get all the data and you did 27 different reconstructions from the OCT that you had. There are challenges in making the reconstruction. Let's go to Claudio as well. Claudio, how confident are you with regards to the decay crash when you have two stents, one going into another, that you have respected the original architecture, you will be able to have the three layers of struct going correctly? Because this may have some effect on the computation of the local hemodynamic forces there.
Yes, of course. So I was not involved in this specific work, so I don't know. I really don't exactly know how the reconstructions were made. But of course, when you have the decay crash, for instance, you have the presence of the struts within the ostium of the bifurcation, and it is very challenging, the three-dimensional reconstruction. And also, if you have OCT in the main vessel in the side branch, it is very difficult to make the reconstructions, and so
I agree.
This
I
may
agree.
have an impact on the final
It's a tricky game, but it makes sense. I mean, also by simulating only bifurcation, like we did in the past with Claudio and Marco Twin, and we saw that there is a huge difference in washer stress forcing when you put two stents, like in the K-crash configuration, you put one single stent and you put a double with a NIT configuration. NIT is in the middle between crossover and the worst, the much metallic technique, like a culotte or decay crash. Culotte decay crash from a computation flow dynamic, there is no too much difference. We saw in the past with Claudio and others. So it makes sense. It's tricky to play, but it makes sense.
Yeah, I think we are seeing here in this study the effect on the entire bifurcation. So looking at the entire geometry. Then if we look specifically at the region of the ostium and we look at the hemodynamics there, then of course we will find probably worse results for the decay crash as compared to the provisional technique. Okay, thank you very much. I pass the microphone.
So the last speaker is bit quantum photon because he's been out and had a talk in the parallel session, Yiannis Chatzizisis, and he's going to talk to us about 3D reconstruction of bifurcation stent bias.
Thank you so much, Nicolas. And I had to go next door to give a lecture and came back. Works well so far. So these are my disclosures. Backgrounds. We know very well that imaging is very useful for our operations. However, we would like to have 3D in real time, if possible, when we do the operation. And of course, imaging itself doesn't give us information about, without the 3D information, about the instant hemodynamic environment. So in a sense, we would like to know more about the stent strats based on imaging, how they're configured in 3D, how they impact the local hemodynamic environment. OCT has the high resolution that allows us to see the 3D reconstruction in real time when we get the pullbacks. But with IVUS, we don't have this capability yet. So our effort here is to show you how we have this ability. It's possible now with high-definition IVUS to also achieve 3D reconstruction of the stent. So essentially, I'm going to describe this technique and then experimentally validate this and show you some clinical feasibility of how we can precisely reconstruct the stent struts, not by OCT, which we do already, but by high-definition IVUS. What we do here, we created a silicon-based coronary bifurcation model. So we took patient information and we replicate these digital twin models into the computer, from the body into the computer using silicon materials. We did provisional stenting. I'll show you. Then we did a pullback with high-definition IVUS, then stent segmentation, and then finally 3D stent reconstruction. So this is the procedure, two patient-specific silicon-based models. You see here on the left is the stereo microscopy. After the stent, it's LED diagonal models, patient-specific. The first is stent with a Megatron stent, the other with a synergy stent. And then on the right, you see here the angiogram, provisional crossover technique. Then we do IVUS, high-definition IVUS. As you can see here, we do segmentation of the IVUS frames. We stack them all together in 3D, and then we create the digital twin of the stented silicon patient-specific model. Then we segment the struts of the stent, shown here with blue, and then we put them all on the 2D, as shown on the top right. And then we do something very interesting. We match these segmented blue points with the manufacturer known stent design for Synergy or Megatron, whatever stent we use. As shown here, then we trim this 2D pattern, just the edges, And then now we have essentially the, in 2D, the particular configuration of the stent struts, matching essentially the manufacturer design to the actual particular individual case segmented stent struts. And then we put it all into perspective, into the 3D reconstructed lumen. We roll this back to 3D space, and here you go. You have the 3D reconstructed, specific for this particular case, stent using the IVUS information. Experimental validation, how this compares to micro-CT, which is used as ground truth. First of all, ballpark, qualitatively, you see the stent morphology. On the left, model 1 is IVUS reconstruction, our technique. On the right is the ground truth. Then on the far right, silicon model 2, again, 3D IVUS and micro-CT as ground truth. You see visually they look pretty comparable. And quantitatively, you see here the diameter from the proximal to distal with IVUS and micro-CT, the stent diameter essentially, pretty comparable with a bias difference essentially between those two, nearly zero. And then even more microstrut, kind of like very detailed assessment. You see here on the left, one of the models, the first model, IVUS reconstruction of the stent with our technique. On the right, the ground truth micro-CT. You see here, we have the ability to, in serial cross-sections from proximal to distal, to replicate the percentage of malapose struts using micro-CT as ground truth, and 3D reconstruction by IVUS replicates this microstrut level detail of malapose struts. And then clinical feasibility. We tested how we can do the 3D reconstruction of an implanted stent in a patient. That's a left main stent, a Megatron 408 in the proximal left main. You see it here. And then using a combination of IVUS, high definition IVUS, and angiography. Again, the dots are the EKG gated specific stent strut points of this Megatron stent. Then in the middle, we now match the stent design of this Megatron to the actual patient stent here. And then finally, we end up rolling back the whole stent into the 3D lumen. And you see here, that's the 3D Megatron stent from the body into the computer. And for those who don't believe if this is accurate, now we take back this model on the left and back project it to the actual IVUS. And you see here nearly perfect alignment of the stent struts of the 3D model to the actual IVUS images. And of course, this can give us the opportunity now to run patient-specific CFD analysis. We can do this not yet in real time if you want. We have the computer power nowadays to do all those things, and they can give us important information about the shear stress, the residence time, following Gianluca's talk as well, on how the hemodynamics are configured in particular stents, which can give us the opportunity maybe to optimize the stenting and improve the outcome. So take-home messages. This method that we presented today enables precise, replicable, and clinically viable 3D reconstruction of coronary stents based on HD IVUS. And combined with CFD studies, this method can give us the opportunity to enhance, improve stent optimization, improve our understanding. You can use headsets and walk through like a red blood cell with a camera and see how the struts are deployed in your particular patients. And of course, this can propel research and development within the field of stent design. We can essentially use this information, this technique, to advance and refine our stent designs. I would like to a big thank you to the funding sources, the industry, philanthropy, and of course federal resources from the NIH. A big thank you to the group of engineers and medical doctors in my center. And of course, a big thank to each one of you for your attention.
Okay, any questions?
So, wonderful talk. My question is that in bifurcation, when you're doing the wiring for the side branches, you usually like to go with the OCT as compared to the IVUS. Do you by any chance recommend that we use both these techniques, the IVUS, the OCT as well as the IVUS, to come to the final conclusion as far as the bifurcation stenting is concerned?
The question is whether we can use IVUS instead of OCT. Is that the question, if I understand this well?
Yeah. Because we would like to have the OCT better to designate.
High definition IVUS at this point has the ability, the spatial resolution, which is comparable, not as good as the OCT, but has the ability to give us high resolution imaging of the struts. You can see here that we can segment the struts and create the stents in 3D. So HD IVUS has the ability to help us a lot equally with OCT. Plus, it gives us depth of the plaque, which we don't get with OCT. And it's more advantageous in ostial lesions, and of course, when patients do not have capacity for contrast. But of course, OCT is benchmark, is gold standard.
Maybe one quick question, because I know with the OCT, the speed has increased a lot. Do you get in vivo some effect of the cardiac motion with the bullseye?
What motion?
Of the cardiac motion in the reconstruction?
With the IVUS?
Yeah.
Even the IVUS, there's at this point, I think there's some systems where you can pull back within with 8 millimeters per second. Of course, you lose a little bit of kind of like resolution, but still it's very adequate. Not quite, because with OCT, you don't need to gate the images, but with IVUS, if you go to the conventional speed of half or 1 millimeter per second, you should end up gating essentially the images. As long as you gate nicely, you should be able to come up with reliable results.
Yanni, very nice work, and in this house, reconstruction should be performed in order to look at the effect of the strut apposition.
Imagine doing this in real time, right? With IVUS, not only with OCT, right?
It is the way to unlock the potential of emerging technologies. To ask you about calcification, calcified plaques. You have tried it and you have a better understanding. Do you see any problem when you have a calcified lesion in finding the struts? And the second question it has to do with apposition. You can definitely assess malapposition with confidence, but when it comes to embedment and apposition, what's your experience by using this approach? Because this can have some effect on the Chiastra.
Yeah, so listen, you know, the metal is white, the calcium is white, so there's no contrast. The ability of IVUS to differentiate the metal struts from the hard calcium is not the best, like OCT. But again, you have most of the struts on 2D, segmented manually, and of course you can do this automatically very quickly using AI. And then you take the known manufacturer stent design and superimpose on this. So in the area of calcium, unless it's like the whole stent is on calcium, you will be able to bridge the gap.
There is a question over there. Yeah.
Hi, great work. I understand quite a few of the challenges with this because we've been doing some similar work with OCT. One of the issues is that IVUS understands the arteries as a straight tube. You can create a 3D shape. So when you deploy this clinically, how do you turn the straight IVUS tube into an artery that has a center line that follows the true course of the artery? Is it informed by CT or AI or angiography?
Yeah, if you put my presentation back, otherwise I can describe it. But we don't do straight stacking of the IVUS or OCT frames on the angiographic center line, but we use the angiogram to give us the 3D configuration of the center line, and then we do realistic stacking of the images on the backbone of the 3D, not straight, but 3D center line.
Sure, so the center line of the artery comes from the angiogram.
You create a digital twin. You take the vessel from the body into the computer. You don't make it straight from the body into the computer with precision.
Is there the chance?
Dr. Bourantas has been doing this for his whole life, so this is resolved now. We can do this. And Claudio, everybody here. All of us here. And Nicolas as well, everybody.
So is there the chance now with this methodology to have at least small clinical trial, including these reconstructions and the quantities that you can get from this analysis?
Yeah, very good point, because as I said, the meaning of this meeting here is to push the envelope. So our job, we're using the engineer hat now, is to showcase to the clinicians the technology. And once Dr. Ferenc feels that this is useful for his practice, then take the industry or any academia and translate this into a product that will be clinically impactful. So the concept is that this is doable, because in the past with IVUS we couldn't see the struts just falling in 3D. Now we can see them with these new IVUS technologies, same with OCT. Whether we can do this 3D in real time to help us get better understanding of the stent configuration and the hemodynamics, I think it's doable. We can do this. I'm sure we can do this. We're about to go to Mars. This is way easier, but needs the clinicians and engineers to get together and focus.
And this is necessary also to find endpoints, because we still don't know. We still don't know what we're measuring and what is the cutoff, that the value, it can be dangerous clinically, for example. We don't know. We know close shear stress are bad, but in which area in the stent segment? This is something I'm starting towards.
Yeah. And should we wrap up? Yeah. So just to wrap up, I mean, your talk was a nice example of how imaging, relates to what we learn on the bench and on the simulation. Only with imaging we can go and confirm, in vivo. So the two are interrelated. So thanks very much to everyone, and thank you for the talk.
Thank you, everybody. Thank you.